Hi everyone, sorry about that delay. We've found Mohammed now, he's found us. So Joy, we can go ahead with his presentation, and there's no issue because unfortunately our 3 o'clock speaker had to cancel through illness. So we'll be able to have Mohammed's full presentation, and I'm sure you're all eagerly awaiting it. So Mohammed Hussain is going to be talking about from data to dialogue, a mixed method analysis to target NHS Health Check investment and reduce health inequalities in Birmingham. So over to you, Mohammed.
Okay, thank you very much. I'm really sorry for the trouble. I know technology. Thank you and welcome everyone. Good afternoon. So today I will present our work, and apologies before that. Actually, my voice, as I said, I got some cold and flu over the few days, but I think I'm okay to continue. But as I said, unfortunately, I cannot switch on my camera as well. Okay, so hopefully you can hear me well. I'll present our work title. As I mentioned, that from data to dialogue, targeting NHS Health Check investment. So this talk actually focuses on how we use the mixed methods and participatory approaches to reduce health inequalities in Birmingham. So before I begin, I would like to give some brief, introduction background of this project. So the NHS Health Check Focus Groups project, the report we produced in March 2025 was prepared by the public health team at Birmingham City University in collaboration with Birmingham City Council. The project aims to evaluate the NHS Health Check program through community engagement and participatory research. So the researchers include a multidisciplinary team of lecturers and senior academics in public health, reflecting a strong institutional commitment to addressing health inequality. So this presentation actually summarizes key findings, as statistical insight, also thematic analysis and recommendation, which derived from the focus group discussions conducted across Birmingham. So, as you know, that Birmingham is one of the most ethnically diverse and socioeconomically deprived cities in the United Kingdom. So over 50% of its population actually belongs to global majority communities, including South Asian, Black African, and Black Caribbean groups. And approximately 88% of Birmingham's wards are more deprived than the England average, contributing to a significant health disparities. And the residents in the most deprived areas are, 3 times more likely to develop cardiovascular disease compared to those in more affluent areas. So the city also faces, elevated rates of diabetes and obesity, with 9.3% of adults diagnosed with diabetes and 68% classified as overweight or obese. So these statistics actually underscore the urgent actual need for targeted preventative healthcare intervention like the NHS Health Check program. As you know, there's NHS Health Checks are a cornerstone of the preventative healthcare strategy. So designed to identify individuals at risk of cardiovascular disease, including diabetes and other chronic conditions. So despite their importance, what you see that uptake among racially marginalized communities in Birmingham remain disproportionately low. This disparity undermines the effectiveness of the program and perpetuate health inequalities. Commissioners like Birmingham City Council and others, decision makers have, historically relied on high level of statistics which fail to capture the, nuanced barriers faced by these communities. Without, granular community-specific evidence, intervention, risk being, generic and ineffective. So the challenge actually lies in understanding why, the majority of eligible individuals are not attending these NHS health checks, and how to design culturally competent solutions that resonate with diverse population. So this context sets the stage for a participatory mixed method approach that moves beyond data collection to meaningful dialogue. So that's why we mainly focus on actually focus groups, ensuring that insights translate into actionable strategies for improving public health outcomes. As we mentioned, that primary aim of this study was to uncover the specific barriers and facilitators influencing NHS health checks uptake, across 10 ethnically diverse communities in Birmingham. We included 10 diverse ethnic groups in Birmingham. So rather than relying on broad demographic trends, the project actually sought to generate actionable insight that could inform local commissioning and service design. So by adopting our participatory approach and the mixed method approach, actually, we aim to bridge the gap between the statistical analysis and real world experiences, which ensure that interventions are both evidence-based and culturally sensitive. So this approach reflects a commitment to equity and inclusivity, recognizing that effective public health strategies must be tailored to the unique needs and perspectives of the communities they serve. The methodologically, what we've done actually, we use, as you mentioned, we keep mentioning that participatory action research model, and we work with 10 community organizations, and the participants were there 193 participants. So this ensured actually, which is culturally grounded, as well as trust-based data collection. We combined quantitative with qualitative. With the analysis, we did framework analysis actually, and we did a double-layer sampling strategy across ethnicity, gender, and as well as, of course, and the age to capture the diverse perspective. So this triangulated approach mainly strengthened the validity of our findings and ensured that the community voices remain central to the analysis. So this is just the table which shows here that, as we mentioned, there are 193 participants, and out of 193, 13 actually NHS health professionals we included. So out of 180 community participants, of which 153 participants were within the NHS Health Check eligible age range, for example, 40 to 70 years. However, only 45 participants reported having attended an NHS health checks. And as you mentioned, that participants represented 10 global majority groups, for example, Arabs, Bangladeshi, Black Caribbean, Chinese, Ghanaian, Indian, Nigerian, Pakistani, Somali, and also white British group. So the average age was 52.11 years, and the gender distribution actually varied across groups, with some communities showing balanced representation, and others, such as Chinese and Nigerian, having a higher proportion of female participants. And uptake rates were notably higher among Chinese and Nigerian groups, while Arab and white British men showed no participation, indicating actually significant disparities in engagement. After the demographic information, the key findings actually, some of the key analysis that revealed a statistically significant gap between the number of eligible individual and those who had received an NHS health check. So many participants had never received an NHS health checks, and many participants actually had never heard of NHS health checks. so which stress the importance of this evidence for commissioners. And as we mentioned, mainly actually we focused on qualitative findings, so which we find that we find the list barriers, for example, low awareness, misinformation, unclear letters, and logistical challenges. Also, lack of culturally sensitive advice and as well as mistrust. So the thematic analysis identified lack of awareness as the most pervasive barrier, with many participants unaware of the programs that NHS Health Checks actually exist, or if they know something they never heard, they're not sure about the benefits of NHS Health checks. So among those who were aware, misconception the purpose and outcomes of the NHS Health checks were common, further deterring participation. There are some systematic barriers we found, included ineffective communication strategies, such as they found the invitation letters they received is not clear, and logistical challenges which you mentioned, like inconvenient appointment times. Additionally, the absence of culturally sensitive advice, and another deep-seated, which is historical deep-seated mistrust of healthcare institutions, which they mentioned, that emerge as critical factors as well. So these findings actually underscore the complexity of health inequalities, and highlight the need for actually multifaceted intervention that can address both informational and structural barriers as well. So the impact and policy and the influence, on commissioning and service design, which we think that the findings we provided to Birmingham City Council with we believe that which is a robust evidence-based to transition from universal that one size fits all commissioning to targeted data-driven investment. So they're aware that actually, as you know, that one size will not fit all, and that so by identifying specific barriers and facilitators within the diverse communities, this project actually informs the redesign of the communication strategies, which can be clearer and more culturally competent. And it also supports the development of community-based delivery models and that can enhance accessibility and trust. Also, these changes that aim to maximize the impact and the value of public health spending, that ensuring that resources are allocated where they are most needed. So beyond, we also identified that beyond Birmingham, this approach can offer a replicable model for other local authorities, seeking to reduce health inequalities through evidence-based and participatory strategies. Some of the reflection, while the participatory action research model proved highly effective for building trust and generating rich, diverse data, the process of co-designing research materials with 10 community providers was actually time intensive. So this one of the challenges. This challenge highlights the importance of allocating sufficient lead in time for collaborative design phases actually in future projects. So early engagement with the community partners can also streamline the process and enhance the quality of the materials produced. Additionally, the future research could explore the integration of digital tools to facilitate communication in coordination among stakeholders. So some of the lessons underscore the need for flexibility and adaptability in participatory research that can ensure ensuring that methodological rigor is balanced and as well as practical consideration. Nearly ending. So the research actually demonstrates that data alone is actually insufficient to drive meaningful change in public health. So dialogue communities is essential for translating insights into actionable strategies that resonate with those most affected by health inequalities. So by embracing participatory mixed methods approaches, analysts and policymakers can design interventions that are both evidence-based, also importantly culturally competent. So this shift from extractive data collection to genuine partnership represent a critical step toward achieving health equity. So as we move forward, the challenge is to embed these principles into routine practice, ensuring that every voice is heard and every intervention is informed by live experience. So I think this will be my last slide. So the communities, just the thing which said the communities are not just participants. We didn't, treat them as only participants. We treat them as in our research. They are essential analytical partners as well, whose lived experience reveal what data alone cannot do. So we work with communities rather than merely studying them. Actually, we gain insight that is richer, more accurate, and far more meaningful for preventing health inequalities. So the dialogues create, of course, better evidence, because real conversation exposes with the everyday variants, the hidden assumptions and the cultural realities that show that shape, how people engage with NHS health checks. And this is evidence, rooted in context, trust, and also lived experience. So lastly, the better evidence, of course, it delivers better impact, and it guides commissioners towards targeted investment. It of course it also strengthens that service design to be more culturally responsive, and ultimately it improves the health outcomes of the communities we serve. So when communities become co-creators of knowledge, public health becomes more equitable and more effective, as well as more human actually. So I think this is the end of my slides. And thank you for listening. I'm happy to take if you have any questions. And I'm not sure whether I have more team members here because I cannot see anyone.
Thank you very much, Mohammed. That was a really, really interesting talk. And yeah, audience members, please do put your questions in the Q&A or the attendee chat. We'll pick them up there. But just to start us off, I've got a couple of questions and comments, Mohammed, that'd be really good to discuss with you. So I'm part of a big programme of work that Cancer Research UK is funding, that's looking at better detection and diagnosis, and we did some very preliminary research through our ADR Wales partnership, with researchers accessing data through the SAIL data bank in Wales, and that was to look at differential rates of uptake of cancer screening programmes for breast and bowel cancer in Wales, and it showed a really, really similar differences in ethnicity. And obviously, if people from minority ethnic backgrounds aren't coming forward for screening, then they're less likely to be diagnosed and likely to have worse cancer survival outcomes ultimately. And that analysis hasn't been done yet, but just really wanted to stress the importance of the work that you're doing to understand why people are differentially engaging with NHS services. But I mean, in terms of the feedback you had from your public participants, how did they feel about the NHS after the end of the process, if you like, compared to at the start?
So as I mentioned that there are various different types of outcomes, findings we found from them. That, as I said, that one of the main problem is they have a lack of awareness within the community members about the NHS health checks. And then and another thing is for low uptake, there are many, for example, some, really cultural issues, especially as we see, what you see in our study that women are ahead of men participating in there, and we would see more. One of the for men we see that is the logistic. Logistic. The problem is that they're not available when the NHS health checks, are conducted. And for women, we see women participant, but they want to see more culturally sensitive, for example, more women during the test, rather than men. And so these are the things. And another thing is, they want something to be conducted within the community. So some of the participants, they wanted to see rather than going to a GP or any other institution, they want to see it in the community. So these are the things they want to highlight, and as well as the invitation they received, which although we know that there is a different languages going through the invitation, but some of the invitation should be level, as that is really important, because we heard from some of the participants mentioned they received a letter and they said, okay, we receive letters every week, and we didn't know that one is really important because that was not targeted. So something like, if someone within the family, if I am over 50 and if the letter goes via my name and then must be opened by the receiver, something like this, they might think, okay, this is really important for me, so I must, if they say, okay, contact you, but this way, they said it's not coming that way. So some of the intervention, it can be this way, so that they find it's really important. But the more participants actually will be attending, these NHS health checks, even know the importance of these NHS health checks. Rather than not knowing what is it actually.
Yeah, that really speaks to the first question in the chat, actually. So Harris Wong has asked, what are some learnings to build trust and get people engaged in the research in the first place? Because at some level, the people that you're talking to were engaged enough to take part, weren't they? So So how do you do that first step even?
So I'm sorry, can you hear that again, please? Question.
So the question was, what are some learnings to build trust and get people engaged in the research in the first place?
Okay. Yeah. So
yeah.
So the getting the trust, actually, we need to get to the community members through the trusted gatekeepers. For example, some of the Muslim participants, some of the, they mentioned that mosque imams, or through the local communities, rather than coming from the institution like Birmingham City Council or NHS. So if a religious leader tell them, okay, this is really important, we need to get to this, so they will definitely listen to them, then reading some letters, so there's one of the thing, that's the trusted thing. And another thing is which is already being done, that their own languages. Also, they need to have some kind of community champion. They can go to them and then tell them, then these are the test you'll be doing is something that will be really helpful for you, because this is the risky age. This age, we do this, you're eligible, you need to get this. So they want to hear from their own community member.
Yeah.
Then someone, so that would be really good way to gain the trust from them.
Yeah, no, that's a really good point to finish on. We're out of time now, but thank you very much, Mohammed, for joining us, and thanks for a great talk. And we've now got a 20-minute break, but please do come back in 20 minutes for our first talk of the next session on social return on investment. That should be really interesting as well. All right, thank you very much.
Thank you very much.